I'm really honored to have this opportunity to keynote our 11th PHI conference on post-polio health. And it's really great to see everyone here, a nice crowd, newcomers and old faces that I recognize, old friends. And my goal here today is to do a review that will be sure that newcomers among us have some of the same information, I guess, or at least know where the rest of us are coming from on the issue of the late effects of polio. And then also hopefully pepper that with some new ideas that will be perhaps still of significant interest to the old-timers, if I can use that expression. I have a lot to cover, and I've told Joan ahead of time that I'm not going to actually, I'm going to use the time to cover as much as I can and let questions come out in two major fashions. One, I will be around for the duration of the conference, as will several other very knowledgeable physicians and professionals that you're more than welcome to corner in the hallways or the in-between sessions and get into more extended question and answer. The other is many of these topics, which I will cover very briefly or introduce you to, there will be a session, okay, that later through the conference that will deal much more expandedly with that topic. And those will all have opportunities to ask even more detailed questions. So for those reasons, I thought we would use this time, or I would use this time, since I guess it was my choice, to cover as much information as I could with everyone. Okay, well, some of you know that I've spent a lot of time recently talking about wellness. And, you know, health and wellness, I guess good health and wellness are often used interchangeably. But certainly wellness is a more expanded concept, perhaps, than our physical health alone. Most of us that have dealt with disability-related issues also recognize that you can be disabled and still be healthy. And that wellness is certainly more than just the absence of a new illness, but it really is a much more holistic concept. There's many models for looking at and considering the topic of health and wellness. Those were a few on the first slide. This is another one of my favorites that an old colleague, Roberta Trishman, talked about years ago, and because it looks at wellness as a balance, a homeostasis, if you will, between the organic and physical issues in our lives, our physical body, but also our mind, the psychosocial aspect of us and the people around us, and also then that physical environment. And they're saying that when anything changes in any one of those three realms, there has to be an adjustment in one or both of the others in order to still get to a point of equilibrium. And as Joan mentioned, and you'll hear me say more than you want to probably through this talk, life is about change. This is the model I've used more frequently because it's a little easier to hang on to and reminds us very easily about the relationship between our body, our minds, and our spirits. And it's important to keep reminding ourselves that all three need attention, okay, to keep at their optimal, in their optimal health and a state of wellness. So certainly health and wellness are, in the way I'm going to be talking about it, pretty much the same. Quality of life is a related topic. It's not exactly the same as wellness, but it's awfully close. It is possible to be healthy and not have a good quality of life, or the reverse, but usually they're pretty closely correlated. And people in here certainly know that you can have a disability and still be quite well and physically healthy. They're not the same thing, even if a lot of society doesn't remember that. And then this last question is the critical one, I think, for us to face today, which is this issue of do the components and expectations of our wellness change as we age? And I think you'd have to all agree pretty quickly that they do. And I'm going to spend the first part of our time together this afternoon talking about what I sort of would simply say were some categories of change in your life as a polio survivor. And if the late effects of polio are late, then that would, by definition, mean that they follow some considerable years after the acute polio event. Well, if years pass, then you're also growing older. We call that, in most research circles, that's your chronological age, okay? And the others is sometimes called the number of years post-onset of disability, post-injury, if it's a traumatic onset of disability. But for many polio survivors, they're not much different because so much of polio and the polio epidemics were among children. And certainly if you're under 2 or 3, when you had your acute polio, it's not much different than having had it your whole life, the effects of it. Okay, now we can talk first then about category of change, which is secondary complications of the polio itself. And I'd like to just remind everyone that there's really 2 kinds of those. And I was reminded of this recently in some communication we had with some physicians in Mexico and the third South America, that we're struggling with this concept about sequelae of polio, because you do have initial sequelae of polio. If polio affects the nerve cells through the poliovirus infection of the central nervous system and damages or kills some of the motor nerve cells and leaves people with muscle weakness, the initial secondary complications include things like if you were a child when you had severe weakness, there wasn't enough muscle to make the arm or leg, the limbs, grow to a normal length, to a normal size. It may have led the vertebrae to not form and develop in a usual way, and so we're left with scoliosis. Those are some of the more common, simple examples, I think, of what I mean by initial sequelae of polio. And I would differentiate those from the major topic that got us going as an organization and as a big post-polio community, which is this notion of the late effects of polio and the specific sequelae that has become known as post-polio syndrome. So a brief review for those who haven't seen these slides before, and I suspect many have, but if our muscles are normally controlled and run by nerves that are located in our spinal cords and known as anterior horn cells or motor nerve cells, they have a long process that then would run through the limb and reach the targeted muscle, and when an impulse is fired down that, then the muscle would shorten and contract. And when those nerve processes like wires reach the muscle, they divide into smaller and smaller branches until they form a little neuromuscular junction, the little circle on there, that is the connection between the nerve impulse and the actual muscle response, which is contraction. Now, after the polio virus infection, if it's paralytic polio, then people were left with various amounts of losses of anterior horn cells going to different muscles. Some muscles may have been 100% lost, other muscles perhaps only 10, 20, 30, 40% lost. Most muscles have in the neighborhood of 100 or 200 nerve cells that control them, and normally if you can lose in the neighborhood of 20 to 40% and hardly know it. You notice it more if that happens quickly than if it happens slowly. In polio recovery, the people work on exercise and get their muscle fibers, the brown things over here, they all get a little fatter, and so they then are stronger. There's more muscle tissue. But we also have learned that one of the major other mechanisms that allowed people with polio to recover, particularly in the muscles where they were able to move them just a little bit, but not very much, And when they worked on that with a long period of exercise, they got it to become a useful muscle, okay? And one of the ways that that happened was what we call sprouting in polio recovery, which is a growing out of new little sprouts from parts of those intramuscular branches on the nerve, so that now one nerve cell can actually reach and control 3, 4, 5, even as many as 7 or 8 times as much muscle tissue as a normal muscle would typically do. Therefore, you can still get pretty good force out of your muscle, even though it's being only run on half horsepower, so to speak, because there's less nerves to it. Well, when the late effects of polio with post-polio syndrome come along, we now are really still pretty sure that one of the major mechanisms for that is this phenomenon that's become known as a dying back of these old sprouts, okay? So that when the nerves become, when the person who has the nerves is becoming older and things happen to their health and their immune system perhaps, then there tends to be a dying back of these sprouts. So the muscles or the nerves, and therefore the muscles, shrink back to perhaps what they looked like in the early period after the acute polio infection. There are probably other mechanisms that play a role, but this is the one that we've sort of focused on the most. Now, exactly what we mean by post-polio syndrome has been a great topic of conversation, particularly among us medical people. Trying to come, because if you don't have a commonly understood definition of a secondary condition like post-polio syndrome, then it's hard to do research on that condition that is convincing to everyone involved and make conclusions. This is what I've generally used as the definition, the criteria, the diagnostic criteria, to say which polio survivors in fact have now developed post-polio syndrome. And it's based on the March of Dimes, one that was a conference of consensus conference definition of experts about 15 or more years ago. A European group of experts has come up with a working definition by people in Europe, and it's pretty darn similar. I wouldn't say there are major differences to it. And the critical ones of that definition include that obviously a person has had to have a prior history of polio with residual loss of motor neurons, that is paralytic polio, and it has to be confirmed by either a typical history and exam, if not formal records, which most of the time don't exist. And sometimes special tests such as electromyography may help in that confirming if it's in doubt. Secondly, there should be a period of stability. A person should make a recovery, and then things should stay about the same for a period of at least 15 years. Most of our American polio survivors have been fairly stable for more in the neighborhood of 25 or 30 or 40 years, but it should be a period, and most people have used about 15 years. Now, number 3 is this issue of the symptom that would define post-polio syndrome has to be new weakness. It can be rather slow to come on, and all of a sudden now you can reflect back and clearly I'm weaker than I used to be, but it could be, and it's more distressing often, when it seems to come on fairly quickly, even though fairly quickly is not usually overnight, but perhaps in the course of a few months or weeks. It can seem very quick. And frequently, other symptoms such as pain, fatigue, noticeable change in size, breathing problems. There's certainly a lot of other very common symptoms that come on that are reported at the same time, but there must be new weakness if we're going to call it post-polio syndrome, because some people can get new weakness and they don't have pain. Okay, and it's the only thing that makes sense if we're going to clearly link post-polio syndrome to a late sequelae of the original paralytic polio infection that affected the nerve cells. Fourthly is this most difficult of the criteria, which is the exclusion of other medical conditions that would be causing the new weakness. And this is the one that we struggle with the most, because certainly if someone becomes severely ill from another condition, whether it be a heart attack, a stroke, or perhaps a serious accident, they're going to become weakened, okay, as they're out of commission, okay, for a period of time afterward. And so if they recover from that other condition, but then they're clearly still never get back as strong as they were before, what was the reason? Is that really because they had post-polio syndrome, or do we attribute this new weakness to this other event, okay, or condition that happened in their life? And so this becomes, I'll refer to this again through some of my talk, and I suspect you'll hear this brought up and discussed through other parts of the conference, because there's no clear answer, I think, to that question, and it is a very difficult one to ultimately get agreement on. If you had 3 physicians and they all saw the same patient, took the same history, and they say, all right, now did this other condition explain it or not, I suspect most of the time you would not get a 3 out of 3. You would get 1 or 2 saying one and 1 or 2 saying the other. Now, there's many theories for the causation of PPS, okay, as to why is it? Because most of us who certainly know large groups of polio survivors all recognize that there are some polio survivors who do not have PPS. They seem to have been growing older. They may have slowed down. They may seem a little weaker, but they clearly feel that that's nothing out of the usual because now they're 70, okay, or 60 or 80. And so, what is it that causes a person in their 30s to suddenly really get a lot weaker than they were just a year or 2 before? Because we've all seen some of those people. And there's lots of people in between what I would say are those 2 extremes. Well, one has been, and there's still a lot of discussion, and you'll hear hopefully some update on research. Our friend from Italy is here with her. You'll hear more about some of his work and ideas. But it's exploring further the immunological theories, because certainly as a viral infection that the body responded to by making antigens and protecting us from reinfection, and certainly that's what the vaccine for polio was based on, immunology is important. And there are some clear immunological abnormalities that we see in older polio survivors. And so there's a lot of reason to be suspicious that one of the things that seems to affect or that changes and that leads to change in strength among older polio survivors is immunologic. Others include a normal drop-off of number of nerve cells. We all tend to lose nerve cells in our brain and our spinal cord. But the question is that accelerated? Does it happen at a higher rate among people who've had this old bad infection, okay, that some nerves survived? Do they have the same longevity, those nerve cells? Another one is the whole issue of overuse. And not only do you accelerate perhaps the nerve cell deterioration because that nerve cell's been working harder all those years, firing 6 and 7 times as many muscles as it normally would have to do, but also are we just wearing out our body parts, particularly our joints, our tendons, our ligaments, the things that hold the bones and the muscles to keep them attached and allow us to move around. Athletes, for example, there's no question that professional athletes that beat themselves up, okay, they do have more musculoskeletal problems as they get older, okay, because that wears them out. And there's a lot of similarities to the way some polio survivors have had to live their life in order to survive well and remain functional. But then there's the flip side about the underuse question, okay? Because we may have accelerated disuse atrophy, so that when we do develop a problem that requires us to rest, whether it be a serious new illness or an aggravating pain problem from strain, and we rest to get it better, does our do polio muscles weaken much faster from that little bit of, that shorter period of underuse, and then they never can get it back again. You see, that's the underuse kind of theory. So we have an accelerated disuse atrophy contributing to this new weakness. People have talked about toxin exposure, but I'm not going to say a lot about it because the research kind of went nowhere with that. It's an interesting question, but there's not yet been a lot to support it. And then there's the issue of stress, because whether it's environmental stress from a flood or a tornado or a war, okay, which is extremely stressful and will likely cause physical problems, including deterioration of strength, and if you were a polio survivor who got caught up in something like that, or social stress from the death of a spouse, horrible fight with the family, psycho-emotional stress, development of a mental illness, or physical stress, okay? Because getting a new disease, having a horrible injury is an extreme stress. Body has to respond to that with stress. Guess what? The stress affects the immune system. The stress eats up some of your muscle metabolism, okay? It slows you down. So all of those things on a stress basis are going to contribute to new weakness. When does that become the explanation versus PPS? How much of it does it take? You can see how the questions become difficult to answer. Well, here's a couple just quick studies I'm going to share with you. Dr. Trojan, back quite a few years ago in '94, did an interesting study in a big review of her post-polio clinic population up in Montreal. And they looked at they actually found 353 people that they had great records on, okay, from having examined. But when they reviewed those people's charts to see whether they met the definition of post-polio syndrome, when they took a critical eye toward acknowledging other diseases and illnesses, in other words, a true diagnosis of exclusion, there were only 127 who met the criteria for PPS, because the majority of them were getting new weakness. There was other reasons to suspect that were contributing to the new weakness, not that it was just post-polio syndrome, whatever is triggering that. Then she only was able to find among her clinic population actually 39 polio survivors who in fact were not having any new weakness, okay? So it was hard to find those people. And then they compared the ones that had no new symptoms, clearly did not have PPS, to the ones they thought had true PPS. And they found, lo and behold, the factors that were associated with having developed PPS were that they were older, which meant they were a little more years living with their polio, that they had the more severe cases of polio when they started. That's undoubtedly a risk factor, in my opinion. Tended to be things also like gaining weight recently, significant weight, having muscle and joint pain problems. Now, I would hold that you could argue that those last three, anyway, weight gain, muscle pain, and joint pain, if they're associated with being more likely to have PPS, you can't differentiate causative. You see, they could be effects, because if you're having PPS, you may slow down and then eat the same amount and then gain weight, okay? Or you're more likely to strain yourself because you're weaker and therefore you hurt, and so you do less and you become weaker. So it's hard to say that they're cause or effect. They could be some of each, okay? But they certainly are going to be correlated with which polio survivors do get PPS. Okay, moving along, other secondary complications, okay? I would put in a slightly different category because I would call them complications related to living with polio sequelae. The primary polio sequelae being, of course, chronic weakness in various parts of your body. But what happens when you live with chronic weakness? In your legs, you wear out your shoulders. We know that now from medical work in people with any diagnosis, whether it be paraplegia from spinal cord injuries, muscular dystrophy or muscle diseases, other neurological conditions. If you're going to walk around with bad limps or using crutches and canes and wheelchairs, you tend to wear out your shoulders, okay? So it's not specific, you say, to post-polio. But it is to disability, and most of them are in that same other secondary complications are usually things like postural pain problems, inflammatory strain syndromes, early age osteoarthritis or severe joint deformities, such as the knee going backward and getting worse as we get older. Now, this is just a slide I've used in many times in talks, which gives you a laundry list of all the physiological changes that the geriatric researchers have shown. That is, as we get into our later years, we do lose nerve cells, our hearts slow down, can't pump as fast or as well, blood pressures tend to rise, The collagen tissue that holds our muscles together and attaches the bones and muscles and tendons together becomes less flexible, okay, and stiff, more easily injured. Cartilage tends to deteriorate and is not as healthy in its size to cushion our joints, so there's more pain and wearing out of the joints. Carbohydrate metabolism changes, okay? We tend to get heavier more easily, we tend to get diabetes. And you see changes in the immune system. Older people do not generally have as competent an immune system. So if you take those as inevitables, whether they happen faster or not among polio survivors, you can see how they could interact with and contribute to causing what seems to be PPS, okay, that is new weakness in our later years, because the immunology is probably part of the puzzle, okay, of what is triggering PPS. And we have age-related losses of anti-horde cells that may be accelerated because of the overuse-related issues. And we tend to have been chronically overusing our muscles and tendons and joints. Oops. So we have this vicious cycle, okay, of musculoskeletal overuse, which produces pain, which requires rest for the body to heal that inflammation, settle down the pain. But while we do that, we get weaker in that muscle that we're not using. And then when we use it again, it is more easily strained from the same amount of activity. And so here we have a vicious cycle of more pain, less use, more weakness, more pain. And this is a really hard thing to break up. Now, the third category of changes that I just want to spend some time on also is this issue of comorbidities of aging. And what I mean by comorbidities of aging are all the new medical illnesses or conditions that happen among the general population in your culture, perhaps your ethnicity plays a role in that, your genetics, but people tend to get more illnesses as the older we get. Things like heart disease, like cancer, okay, diabetes, stroke, getting heavy. So when a couple of things I can share with you. This was an old study I did back in '02 with Michigan polio survivors, and we found that 35% of our sample of polio survivors had significant other conditions beside their polio that were likely, or at least those other conditions were serious enough or significant enough that they could be causing weakness. Okay? That's a lot. Somewhat similar to what Dr. Trojan, another way of looking at that. Two new studies that Joan and I ran into here with our internet stuff not too long ago was this one that I'd share with you by Nielsen from Denmark, where they have a nationalized health service that almost everybody in the country is a part of, and they keep excellent records and have done so for many years. So they were easily able to find 542 people in their computer files, okay, that were known to be polio survivors, okay? And they could age and gender match them with people who did not have a history of polio relative to what their computerized medical record files showed were their other what they were being treated for in their National Health Service system, what other diagnoses had been entered by their doctors. And what they found was that, in fact, polio survivors were at an increased risk of being hospitalized for conditions such as heart disease, lung diseases, conditions of the gastrointestinal system, stomach, colon problems, largely, and diseases of the locomotive apparatus. That was what their words were, but essentially that's walking problems, okay? So it'd be of your lower limbs and potentially your spine. The risk was the highest, interestingly, in their database among the people who had the respiratory polio, which would be the more severe cases, as a child. Then there was this study we found that was published by Dr. Kang, and it's actually from Taiwan. So it was a Chinese population, and again, they had a great big computerized National Health Service type of a database and a registry in that for people with disabilities including whether it was a polio disability. So it did tend to encourage people to get registered in this database because they got some extra services. And what they did then was pull out a matching number of people that were of about the same age, the same socioeconomic groups, same genders, and then they compared their their prevalences of other medical conditions, okay, again, as they were entered by their providers. And what they found is kind of surprising and a little hard to interpret, but essentially their polio population numbers suggested that almost all other physical conditions were more common among their polio survivors. Certainly heart disease, but things like Parkinson's disease, breathing, COPD, which would be obstructive lung disease, rheumatoid arthritis, things that I'm not sure I can understand, but that's what they reported. There were only a few conditions on their long list that they didn't find, and that was something like lupus, tuberculosis, and drug and alcohol abuse, which I thought was rather interesting. But so it may just be maybe a methodological problem, but it certainly, again, is somewhat suggestive that being disabled from polio is risky in terms of your general health. Okay, two more categories that change, and then we'll talk about what can you do about it, okay? One is psychosocial changes. That is to say, remind us all that things like not being able to accept that you need to use a brace or can't do everything that you used to do, and it's driving you to anxiety or depression, or you get depressed because you lost your spouse or your job, which had the economy, not to do with your physical disability. Any of those things, okay, cause psycho-emotional change, they require an adjustment, and they may have a negative aspect on your health, just like an accident might. And then I would remind each other that environmental changes, again, can have really serious negative impacts on their health, whether they be natural disasters, whether they be, again, social problems, losses of spouses or caregivers, disruptive changes in your community or your culture. Some of those can be good, like we think of the cultural change of how the internet and the iPhones and stuff. There's been a lot of positive in the lives of people with disability, safety, a little feeling more confident. But there are some negatives, too, that can affect you from a frustration standpoint, perhaps not as much social contact, which may have some different value than when you're just doing it on Facebook. Okay, well, I want to save the rest of our time here for talking about strategies, what I've referred to as strategies for achieving lifetime wellness for polio survivors. In other words, how do we adapt to the changes? If these are all the changes we're up against, how do we remain flexible? What are the most important things to keep yourself in optimal physical health, particularly those that are maybe slightly different or need to be emphasized as a polio survivor? Okay, well, number one is certainly to optimize activity and exercise. And, you know, there's been an awful lot written about this in the general press now, okay, as the nation has been trying to deal with what's been said to be an epidemic of obesity and diabetes and heart disease that tend to be related. And certainly everyone knows that higher levels of exercise or promoting exercise and higher levels of activity have a lot of benefits, physical benefits. Things like improving your cardiopulmonary fitness, your lipid profile, your cholesterol profile, keeping your weight down, helping you recover if you have another disabling condition, including other neurological diseases. It boosts your immune system, you sleep better, bowels move better, self-image, feel better about yourself because you look better, usually socially. And it's helpful for pain management much of the time. And there's a lot of resources out there that we can share with you if you don't know them. Things like the National Center on Physical Activity and Disability. It's in Springfield, isn't it? Or Champaign-Urbana, maybe it's Champaign-Urbana. But they have some great resources and an internet site that give you resources to help solve the problems of people with physical disability and how can they still exercise in useful ways or more challenging ways, perhaps, that are beneficial to their health. There's a lot of specialized equipment that they can introduce you to or you can find through your local resources, physical trainers, physical therapists, access to pools, to specialized bicycles that you crank with your hand, perhaps, yoga classes and Tai Chi classes that people with physical disabilities can easily still participate in, with sometimes minor or sometimes major modifications or differences. And there's a lot of home options, community-based options, facility options. People often exercise better when they're with friends or peers. And Action Canada had some interesting guidelines about how to work on your fitness that were developed for people with spinal cord injury, but they apply to people with polio many of the times too. Now, there can be controversies about exercise, and many of you have heard that, specifically for post-polios. My thinking on it is that it's naive to say exercise is good or bad for every polio survivor, because it's in the detail of exactly what type of exercise are you talking about, and how intense is it, how long are you going to do it, what way are you going to do it, okay? Is it going to isolate a particular muscle that you're trying to target, or is it going to involve a larger group because you're trying to improve some functional activity or capacity? So it's which muscles and which polio survivors, and do they have PPS? Now, the issue of PPS, for me, is not, I'll get to that in a minute, I guess. These are some definitions, just to have them shared. Exercise, we refer to as planned, structured, repetitive bodily movement. Okay, therapeutic exercise is the same, but it's clearly being done for a specific health purpose. In other words, it's goal-oriented if it's therapeutic exercise. Physical activity is movement during daily activities, which may have some exercise similar benefit in some ways, but it's not the same thing. And the common sense facts are clearly that inactivity leads to weakness and deconditioning, and overexertion can lead to injury, okay, pain, and other problems. So, type and intensity of exercise. I usually remind people there's at least 3 major groups of exercises. One are those that are being done to maintain flexibility and range of motion through joints and stretchability of muscles. Another is strengthening exercises focused to improve the force-generating capacity of muscles, which we usually think about as exercise. And then there are conditioning and aerobic exercise, okay, because we're trying to increase the oxygen carrying capacity of our heart and lungs and the ability of our muscles to use that oxygen. So, exercise and PPS. Well, when I refer to that topic, I first of all like to remind everybody that we're stuck with this problematic definition of PPS, okay, where it sometimes is unclear who really has PPS and who doesn't, because of this diagnosis of exclusion, and hard to know how significant the other factors are. I think the exercise approach is basically the same, except that if you clearly have, the more you clearly fall into the PPS category, I think the more you have to be careful about how you approach the exercise topic, okay, and you may be much more limited in your starting point and what you might expect to achieve during the course of a therapeutic exercise program. But it doesn't mean you shouldn't try it, okay, because you're still more likely to benefit than not. Activity and exercise habits before new weakness, I always put that on there because a lot of polio survivors like to self-delude themselves, okay, that they're just as active as they used to be. They always have been, and they're just getting weaker. But if they take a hard look at it, maybe they're not, okay? So that's what that's in there for. And it's a matter of, again, that holistic look at your stress, general health, and lifestyle as critical issues. Some of the reasons for that perceptual issue of, because most of the time physicians do not have serial measurements to say you're clearly how much weaker than you were 2 years, 5 years, 10 years ago, okay? So we have to rely on what you tell us and your perceptions. Some of the problems are that many polio survivors were unaware that they had lost nerve cells in some of their muscles, the ones that were relatively modestly or minimally affected. And then the problem comes out later on. But when it's looked at carefully, clearly that was never a muscle that was completely normal, but was affected, and now it's becoming weaker. So that's one part of the issue. Another is this aging issue, and how much do you expect to lose because of aging? None of us expect to really lose it, but the truth is we're likely to do it. What about the weight gain, you see? And if you're 20 pounds heavier, and all of a sudden you get tired easier, or you're not as strong and your knee wants to buckle, well, how do you know that it's not the 20 pounds? Because it's having to do more work all the time, okay? So is the muscle weaker, or are you just making more demands on it because you're heavier? Then there's the issue of nutritional habits that we'll talk about a little bit more later. There's the underactivity and deconditioning because you got so busy with other things, or you hurt too much, and in fact, that's much more significant than you really want to acknowledge. And then there's the people that are pushing themselves all the time and they just completely ignore it. And everybody else is like, oh my God, I can't believe how much they do with what they have. Oh, it's nothing, okay? And then they wonder why they're wearing out and becoming weaker. And they tend to be the people with the poor pacing skills. Okay, well, some years ago, PHI actually put a task force together to try to come up with what we thought were appropriate professional recommendations on exercise for post-polio. And these were what the group endorsed, signed off on by consensus. And it included the fact that individual exercise programs can enhance the health and functional activity tolerance of polio survivors. That is absolutely best done with some professional supervising, designing, and supervising that program, at least in the beginning, okay? And it certainly is much more helpful when those people have some basic knowledge about what post-polio syndrome is and what some of the pitfalls of it are. 2 months is usually a minimum before, some 6 weeks perhaps, 6 to 8 weeks of that professional supervision. It doesn't have to be every session, it might be once a week, but somebody to look at that and find out how you're doing. Are you making any progress? Is it causing any new pain problems? How could you do something different? Should you do more? Are you doing too much? Following the general principles of low to moderate intensity with an expectation that progress will be slower than perhaps a person who doesn't have a neurologic disease, and that pacing is a very acceptable and very useful mechanism to use as part of your exercise program. And sometimes it's these issues of less frequent bouts. Perhaps it can't be every other day, but only twice a week, and longer durations of time. The less often you do it on a weekly basis, the probably more months you're going to have to do before you see clear results. It's the way it is. Another issue is which muscles to target. Those who are interested in this could refer to Dr. Halstead's study, which was a method of using EMG as well as history to try to differentiate which muscles might be at biggest risk of overuse damage from a targeted exercise program. Certainly, targeted exercise programs should have a therapeutic goal. Pain and exercise, well, I bring this up because one of the pains that can occur with exercise, if you're trying to build up the strength of a muscle, is the muscle may ache. And that can be, of course, a sign of post-polio syndrome. But the truth of it is aching to some degree, a low degree of aching in a muscle is what a normal person will experience if they do a vigorous exercise for the purpose of getting it stronger. And some research suggests that that's almost it's a very good way of saying you did enough, okay, to stimulate the body to actually make more muscle tissue. So you can't be too hypersensitive and worried about any pain in the muscle, or you may miss the boat, okay, or the opportunity to benefit from it. On the other hand, it should be modest and quite livable and not persistent or disabling. I mean, those are common sense issues, but I do bring them up. Certainly, if you do too much and you do it in the wrong way, it is going to cause pain, and then you will stop using it, and then you're going to get weaker, and it's going to work against you. So, acute and chronic stress and strain syndromes can involve lots of different areas. Those of you interested in the topic of pain, there's a couple panels going on this week where we'll talk about the pain generator, because it's important in terms of designing treatment programs to know, is the pain really coming from muscle, or is it really tendon pain, inflammatory tendon, muscular, myofascial pain? Is it really coming from the joint, the ligaments around the joint? Is it coming from the spine and the discs in the spine? Are they trigger points in muscles from overuse? Is it a stress syndrome like fibromyalgia or something going throughout the body? There's lots of different targeted areas that can cause you the pain. Ultimately, you got to work closely with physicians and therapists and other providers to be able to come up with the individualized program that's going to help you get stronger or control the obstacles like pain that may be in the way of you getting to that goal. The other one I mentioned is the use of adaptive equipment. For some people, the only way, there is no way to get it stronger or certainly to control the pain unless they start using a device, whether it be a cane or a crutch or a brace or a wheelchair part-time or a scooter cart part-time. Those are all ways of dealing with the decreasing capacity, okay? And so I put that up there as another strategy, you see, to control pain and maintain good overall strength and wellness. Okay, so concluding the exercise discussion, some muscles can improve strength and endurance, been shown in a lot of studies. Some post-polios can clearly improve fitness. We've shown that in a number of studies by a variety of researchers. Interval training and pacing are one of the critical pieces to the success of those programs, and then the goals for exercise should be clear to you and the providers. Okay, other strategies now for achieving lifetime wellness. Well, certainly nutrition, sleep, and stress, and other things, almost all people that write about health and wellness will include those, okay? They're very, very critical. Unfortunately, there's not been a lot of targeted research on those topics specific to polio survivors. But I think it's hard to disagree with a few of these that I would put up here to remind everyone, okay? They're common sense. One is it's important to monitor your body weight and your diet and fluid calorie intakes, et cetera, so that you don't become heavy. Because not only does that increase the stress on weakened muscles, makes mobility harder, but it tends to be associated with bad lipid profiles, high cholesterol, blood sugar profiles, obesity, and all of those things have these very, very high correlations with developing arteriosclerotic heart disease, strokes, poor circulation in the legs. All of this stuff is a cluster. Okay, and so it's important, okay, just like it is for the general population to pay attention to that stuff. And diet is critical to that. Fluids and fiber are important for colonic health, okay, so we need lots of fiber. Lots of fiber also tends to help control high cholesterols. Swallowing difficulties are something to pay attention to again, okay, that it doesn't negatively impact your good nutrition. If you can't swallow solid foods, can you get protein, good protein sources through liquids? And so you're not just eating a bunch of sugar. Food composition and quantity, I'm a firm believer that that's extremely important, and that often needs to be individualized because for some people, high cholesterol or high carbohydrate diets may be very good. Other people, they're the absolute wrong thing. They need the high protein diets, you say. So it's not one size, I think, on the food composition that fits all. But I do believe that it's more than strictly calories. But ultimately, you got to pay attention to, is your weight going up or you're down? Is your strength going up or down? Okay, because that's the proof of the pudding. Medication effects are another issue, okay, that affects overall nutrition. Many, many medications that are being prescribed do affect your ability to absorb critical nutrients, okay, in the body, or affect your appetite or your activity. So again, minimize your amount of medications, including alcohol and other substances, which you could call medications, okay, if you will. Maybe medicating our minds in part, keeping us happy. Vitamins and mineral intake and levels, okay? And the particular ones I would mention are the vitamin D and calcium issue for bone health. And then there's vitamin B12 and folic acid that are critical not only for anemia control, so you don't get anemic, but also for polio survivors, very important to not see diseases of the peripheral nerve, something known as peripheral neuropathy, from developing. Because that will really cause a lot of new weakness very quickly in polio survivors whose nerves tend to not be real healthy to begin with because of the polio. Then we have zinc, vitamin C, or some of the others that are critical to nerve function and nerve and muscle function and health. We have a seminar coming up later in the days of the conference on sleep. Some of the ones I just quickly mentioned, sleep habits, like what time of day, the environment you're sleeping in, what you've done right before your sleep. Lots been written on this topic, very, very important, but you do need to ensure that you're getting a good night's rest. Pain control, bed positioning, pillows on the right stomach side, all of those are often big issues for polio survivors, okay? And often a professional dealing with a pain problem may be very key to giving you some of the best advice on those things, watching medication use in that regard. Sleep apnea and the breathing problems of sleep apnea and nocturnal hypoventilation, both that can be very common in the polio population, especially if they had any history of breathing involvement in their acute polio period. But even if they didn't, they're at an increased risk probably for doing that. Some of the Brazilian studies have shown that. And there's a lot of great sleep aids, both the non-medical ones as well as medical ones. Whole big topic to itself. Stress management. Again, where do we start? But certainly education and training on techniques that have been helpful in stress management. I think yoga is a terrific one for aging people with various physical problems. Transcendental meditation was useful, and again, doesn't require a strong body, strong mind. Mindfulness training, massage treatments, all of those can be extremely helpful for stress management. You can go to lots of seminars and workshops, okay, and there's lots of books out there on stress management. If you can't figure it out yourself with your family and friends or clergy, there's lots of other professionals, known as psychologists for the most part, who can give you counseling on stress management, whether they be specific stress issues, you know what its cause is in your life, or you maybe don't know the cause, or it's more general. And I think medications for anxiety are a last resort. They really are much, much overused in our society. There are lots of reasons people who are getting older and more vulnerable can get anxious, okay? But there's lots of ways to control them without medications. Maybe that's a crutch for a short period of time, that's okay, but you don't want to get dependent on it over the long term. It's a dead end. Okay, another strategy that's a big one, okay, is this issue of preventing complications and or recognizing and treating them early. Some complications we can't stop. We are getting older, we're going to get other things. But if you know what's coming and have a higher level of alertness of what to watch for that you might be at increased risk for, then you can get in to see somebody who can help you figure out the best way to dealing with that early rather than when you've exhausted everything that you can think of and are miserable, okay? So, obesity, we've already spoken to, okay, about how it compromises mobility and leads to overuse, and it's common with age-related problems and changes in metabolism and predisposing to diabetes. I can't say enough, we could do seminars. I think there are some sessions coming up on how to control weight. This was a study done in spinal cord patients. You probably are at increased risk because of having less muscle tissue. Muscle turns out to be the biggest target organ for insulin. Okay, it's what our body, that's where the insulin is useful, is because it contributes to the metabolism of muscles, which is very high of using sugar in our bodies. When you don't have much muscle or you can't use much muscle, you're more likely to get things like carbohydrate metabolism intolerance when you get older. So clearly bad profiles of cholesterol and lipids, especially low good cholesterol and high bad cholesterol, are common among people with any type of physical disability, including post-polio. The aging GI system is another one, okay? And just to remind people that bowel evacuation programs as aging, as aging further controls, slows colon transport time, so people may need to do more things than they used to when they were younger to keep their bowels moving on a regular basis. They need to watch for rectal bleeding. They're just as subject to colon cancers, perhaps more. I don't know that's true, but probably not less. And so colonoscopies and routine things all need to be done, even though they're a bigger hassle to get done, and find somebody who can do that on a person with a significant physical disability. The decreased stomach acid I wanted to mention because it turns out that as we get older, more and more people tend to have a loss of production of intrinsic factor by cells in their specialized cells in their stomach. And if they use a lot of antacids, including the H2 pump inhibitors that people use for GERD symptoms, acid reflux symptoms, that all further interferes with the absorption of vitamin B12 because it blocks the intrinsic factor. So you can be eating lots of meat and lots of good sources of vitamin B12 and none of it gets into your body because it doesn't get absorbed. And so if people are concerned about that and they start getting any tingling or numbness in their feet at all or are worried about that, they ought to get their vitamin B12 and folic acid levels checked promptly by their primary care physician so that they can get treated early. Swallowing and esophageal problems is another good one to bring up on the GI system. Pay attention to it, watch for it. If it's there, get it evaluated professionally by someone who understands it. Other issues of neurological problems as we age. Not only is there the post-polio syndrome that can happen in perhaps as high as 50% or more of polio survivors, maybe even higher if they live to be 80 and 90. Well, I guess that's what that slide is all dealing with. We've talked enough about that, I think, at the moment. Other neurologic problems include things like carpal tunnel syndrome, okay, which is a squeezing of the median nerve of the wrist that leads to numbness and weakness of the thumb. It's very, very common in the aging disability community, including polio survivors, because as you use crutches, canes, and your hands for transfers and all kinds of other activities, you're putting more stress on that, and all of those things are known to correlate with the higher risk of carpal tunnel syndrome. EMG tests are needed if surgery is contemplated. There are lots of other ways to try to deal with it if it's modest, such as splints, special crutches handles, and changing the way you use your hand, changing perhaps the way you push a manual wheelchair. All of those can be helpful. Injections sometimes can be helpful to avoid surgery. But surgery can be done, and if it's thought through, it's not probably any riskier than it is in the general population. It's just that you've got to figure out how to take care of yourself for 3 weeks when you can't use your hand normally after the surgery. That's the challenge usually. But if you enlist the help of a rehab physician along with the surgeon who's going to fix the carpal tunnel syndrome, you ought to be able to work that out. Other musculoskeletal problems common in polio survivors as they age include osteoporosis, that is a loss of the calcium from your bones. Probably it's inevitable in limbs that don't weight bear and have very little muscle. So if you grew up as a kid that always wore one brace, the bones in that leg never got normal amounts of calcium in them. So they will show up as osteoporotic, but that shouldn't be the judge as to whether you have systemic all over osteoporosis. So it's a complicated subject that we're still learning more about, okay, how to decide whose osteoporosis is severe enough that it warrants special medications that have side effects to keep the bone better mineralized. I think most of you appreciate that the best thing you can do to avoid it is to maintain a high intake of vitamin D, calcium, and weight-bearing activity on your feet. Some of those things are not always possible, okay? But to do as much of those things as you can, because as our bones lose calcium, they become more easily fractured with the same amount of trauma, and that's what we want to avoid. Other common musculoskeletal problems as we age include shoulder pain, which I've mentioned before, almost inevitable if you have severe lower extremity weakness. Hand pain is common. We're going to cover some of that in the other sessions. And overuse arthritis of the back and knee joints, wrist joints, hand joints, all of them extremely common. Then there's the issue of the immune system, getting back to that. Not a lot of longitudinal research data on polios to say what happens clearly as they age. But we know that immune function tends to decline with aging in the general population. And we do know that immune system function is depressed by chronic stress. Okay, it's also it's been shown to be depressed in people who are chronically depressed, emotionally depressed, for people that lose social support, that are fighting chronic pain, and are dealing with polypharmacy, particularly a lot of pain medication. And so, again, to avoid all of those things, all that you can should be helpful to maintaining as healthy an immune system as you can. And hopefully that makes a contribution to making it less likely that you get PPS. Breathing issues. Again, a whole topic into itself. We have some great sessions here in the rest of the conference on breathing. We all acknowledge that age-related declines happen. And some of that seems to be the lung tissue that happens in normals. But we also know that the chest wall of polio survivors, particularly those with scoliosis and that had breathing involvement, tends to get tight, loses its flexibility, which further compromises breathing and coughing. And then the diaphragm itself may have been affected and get weaker yet. So those things are just a few of those that really contribute to the increased number of breathing problems in the older polio survivors. Yearly monitoring is the best thing you can encourage your primary physician to do, particularly if there's been any worry or concern about breathing involvement, diaphragm involvement from your polio, or any symptoms that you've had of easy shortness of breath or chronic cough. And there's many options then to consider. Certainly if you have any sign of sleep apnea, it needs to be treated. They need to be certain you don't also have nocturnal hypoventilation, because then you need BiPAP instead of just CPAP. And so again, working with pulmonologists and other specialists who understand those issues is very critical. And there's a lot of things on Polio Place and the other sites that can help guide you in that. Fourth strategy I'd put out to you is educate yourself. And you give you all credit in preaching to the choir, you're here. It's one great strategy to educate yourself, bring your family, your friends, share the resources with them, share them with your primary care physician. Use printed resources, video resources, computerized resources like Polio Place, formal programs and conferences on a local level, on a national level, on an international level. Individualized methods and assessments of learning, okay? You may need a little specific help on various topics, okay? Such as stress management. And then there's the issue of personal empowerment, taking control whenever possible, and using peer support and interactions. Again, you're getting some of that here. Involving yourself in education and training on how you can take better control and make decisions in your life. Tons of great seminars going on, great books, all of them out there on the topic of personal empowerment. And there's some sessions here that are really addressing that topic in one way or another. I throw that study out by Walker back in 1986, not new, but she was looking at what was called a health-promoting lifestyle in those days. And here's what she came, this again, not polio survivors, but general population. And here were the key dimensions. You see, that's self-actualization. Taking responsibility for your own health. Don't feel victimized, okay, or leave it just to the experts to figure it out. Health responsibility, okay. If it doesn't work, go back and tell them. Get the answer, okay. Exercise, nutrition, interpersonal support, stress management. I thought it's right up the same alley. Some of the things we've been involved with over the years, I'll just end with things like living with a healthy lifestyle with chronic conditions, a program developed over at Stanford. Great program. Joan went through a training as a leader for people with physical disabilities. I haven't seen a lot of it going on anymore, but it was really, again, looking at that issue of teaching people with chronic illnesses to take responsibility. We do that kind of in our own fashion here, I guess, at PHI and other polio support group agencies around the world. Key content areas for health and wellness programs, something I've been involved with. Marianne's involved with them now. Nice to have you here, Marianne, from Australia. But body, mind, and spirit, a focus for a health and wellness program with always including aspects of exercise, nutrition, and lifestyle, okay? You know, those are the cornerstones when you want to simplify it in a summary. Some of you remember, the Ortons were here too. It was great to see them. Some of our other people that were in Warm Springs at the last PHI conference where we had the chance to run a health and wellness retreat for polio survivors for the 4 days before the conference itself started. And in fact, there's your picture. Oh, is it the same dress? It's red anyway. I'm just teasing. Great to have you here. We had so much fun at that thing, I'll tell you. It was super, and I'm glad that we've stimulated lots of other people in the topic to get more involved with it. We did so many interesting things. Some of you know that I've been doing that. We've done 6 or 7, I guess, up at Bay Cliff, up in northern Michigan, where I live, on the shores of Lake Superior. It's a sunrise over the lake. Today it's still frozen, if you can believe that. If you saw the Facebook weather pages. And we go on hikes in the woods, regardless of how well we get along, and look for fall mushrooms and blackberries and toads and whatnot. We look at people's individual medical problems, such as their walking, and with an orthotist and specialized brace makers and the other polio survivors chime in from their perspectives as what might help and what they see. We have lots of lectures and conferences and discussions on various topics and subtopics by nurses and psychologists acupuncturists and polio survivor counselors. And we have a lot of fun, introduce people to new equipment, like some of the hand-crawled bicycles that are good for exercise, maybe try them out for some of the first times on the stationary bicycles, or give them some advice of how far to push themselves, have some great swimming classes, and have the water as warm as we can get it. Sometimes that's not real warm up in northern Michigan, but so I would just say in conclusion that these are my conclusions on this broad topic of lifetime wellness with polio residuals, and how to look at the concept of the late effects of polio and keeping your health good, is that no disabilities are static. We do face change all the time, tons and tons of change. And the question is how we respond to that change and what we do about it. I think you have to acknowledge that wellness does look different at different life course stages, and that's a mental game of making those adjustments as to what's still realistic, how to set priorities and goals that are the most important things to you and what you consider your overall wellness. Know that the impacts of post-polio syndrome can be managed. There's a lot of things that can be done to help them in the rehabilitative range, not many in the traditional medical realm of magic drugs, although there's some suggestion that we might have something that's going to be of some help in the near future, but there's where we're at the moment. The impacts of aging may be different among polio survivors. It's probably, they do get a little older earlier, the type of issues change their function at earlier chronological ages than your peers. And it's certainly a little bit of change, maybe more impactful on what you can do for yourself, your independence, but there's lots of ways you can still adapt, but you got to be flexible, open-minded to it, seek them out, find the right answers. And lastly, working with, as a physician, I say this as a professional, work with your professionals, find the ones that will listen and take on a partnership with you, and then you can usually get it done. Thanks so much for coming this afternoon.